Hi, everybody. Welcome. Webinar number 3, season 5. I can't quite believe that it's been 4 years, 2020, since these webinars started, and we're now in season 5. And today, I'm telling you, is going to be one of the most amazing webinars you've ever seen. The role of imaging in prenatal diagnosis and rare eye diseases. And I'm going to hand it over now to my co-moderator, Ramesh Kakanuya. Ramesh doesn't need any introductions, head of the children's unit at LV Prasad Eye Institute, and a member of the executive bureau of WSPOS. Ramesh, welcome.
Thank you, Ken. It's an absolute pleasure to be here participating in the webinar. And we always, being a pediatric ophthalmologist, we work with multi-speciality and sometimes trans-speciality. And today is the day where we have 2 eminent speakers, one from India and one from UK. Ken, can you move the slides?
Oh, sorry. So, I apologize.
So we have Dr. B.S. Murthy. He is a consultant radiologist and fetal medicine specialist at Srinivasa Ultrasound Scanning Center, Bangalore, India. He is indeed one of the leading pioneers of ultrasound practice in India. And he was the first radiologist to practice ultrasound exclusively. And he has a work experience of close to 34 years on the ultrasound technique, and he is the founder of Fetal Foundation of India, which runs completely free obstetric service, ultrasound service, and he has trained many specialists through this foundation. Welcome, Dr. Murthy, for this webinar. We are indeed honored to have you. The next speaker is Dr. Kshitij Mankad. He is like to be called as Kish Mankad. Once again, welcome, Dr. Mankad. Dr. Mankad is a consultant pediatric neuroradiologist and the clinical lead for pediatric neuroradiology at the famous Great Ormond Street Hospital, Gosh, in London. And he's been there since 2011. And he also holds an associate professorship with the UCL Institute of Child's Health. And he had general radiology training was in Leeds, and then intermedicine training in Sheffield, and then MRCP. And he has, you can see in the picture, he's quite adventurous, and he has extensive education and training portfolio, having directed and delivered comprehensive teaching programs across UK, Australia, China, India, and South America. And he also holds and directs pediatric neuroradiology masterclass at Gosh, and also set up a PG certification in pediatric neuroradiology. And it's an absolute pleasure to have you, Dr. Mankad, speaking to us today. And we also have my co-moderator, Dr. Ken Nischal. He does not need any kind of introduction. He's one of the most famous pediatric ophthalmologists currently in the world. And he is the division chief of pediatric ophthalmology and strabismus at UPMC. And again, it's an absolute pleasure to have you, Ken. We have co-moderated many of these webinars, and it's always great to connect with the world through this webinar. Over to you, Ken.
Thank you so much. So the format today is going to be, we have 2 amazing speakers, but we also have amazing discussants, Rita Gamma, Hannah Skanger, Louisa Hopker, and I'm going to introduce them. But before I do that, when we talk about global presence, we have people watching right now from Saudi Arabia, Nepal, Indonesia, UK, Belgium, Sweden, USA, Argentina, Peru. It goes on. This is truly a global village when we do these webinars. So let me firstly introduce Rita Gamma. I've known Rita for a long time. She's an amazing pediatric ophthalmologist, very innovative, always cutting edge. She has a private practice in Lisbon. happily married to Daryl. She's Chief Department of Pediatric Ophthalmology and Strabismus at the Hospital da Luz in Lisbon. And she really is passionate about her work, her family, and flamenco. She's an amazing, amazing flamenco dancer. Welcome, Rita, and we look forward to your discussions on the subject today. Well, Hannah Skanger is, without doubt, my right-hand person at the Children's Hospital of Pittsburgh. She runs the ocular genetics service for us. She's amazing. She is she's presented all over the world, and she has experience in both academic and industry settings, and has dedicated a majority of her career to ophthalmic genetics at UPMC Children's Hospitals. These are her two sons, Alec and Dominic, and JP is her husband. I just want to show you this picture. The last time she was on a webinar, Alec, who was 4 at the time, was convinced her mother was a film star, and I've been trying to convince him that she's not. But there we go. I'm only joking, Hannah. Of course, you're a film star, and thank you again for being a discussant. Louisa Hopker, an amazing, amazing pediatric ophthalmologist. She's a former president of the Brazilian Society of Pediatric Ophthalmology. She got a PhD at the University of Sao Paulo, and she's an ophthalmologist at the Eye Hospital of Parana in Curitiba in Brazil, where she trains pediatric ophthalmology and strabismus fellows. So on that note, I want to say welcome to everybody. Thank you very much for being here, and remember that you can type audience questions into the YouTube comment section. We've also got people from Sweden and India on there at the moment saying, I've missed them. Sorry, I've missed you. So type your questions in, and we'll make sure that our moderators, Akila Acharya, will feed those through to us. And if you want participation certificates, please send an email to admin@wspos.org, and you'll get those probably within about 3 or 4 weeks. Since we're coming up to the World Congress, things are busy. On that note, let me please invite Dr. Rama Murthy to give the first part of his talk, and then we'll have a discussion. I'm going to stop sharing. Dr. Rama Murthy, please take it away.
Namaste. Greetings from India. And thank you, Dr. Ken. Thank you, Dr. Ramesh, for having made me a part of this stellar gathering. I can see the stars of pediatric ophthalmology all present on this forum. And without much ado, I will share my screen and we look at fetal orbits. What can we do as fetal medicine specialists to look at the eyes of the unborn? Let me go full screen. Yeah. Is that all right?
Yes, that's perfect.
Okay, so before I go any further, I would like to dedicate this presentation to my father, Padma Shri Lion, Dr. BLS Murthy. He's not a medical doctor, but he's done enormous effort in facilitating delivery of quality ophthalmic care to our parts of the country, that's southern Karnataka. So we'll get on to business and why should a fetal medicine person be interested in the fetal orbits. That is because as fetal medicine specialists, as radiologists who are involved in fetal care, we look at the fetus, in a certain detail between 18 to 23 weeks of pregnancy, and this is called the screening mid-trimestral anomaly scan. When I use the word screening, that means we offer this mid-trimestral anomaly scan across the board to the entire population of ladies under one's care for a detailed anomaly scan. And a part of detailed anomaly scan is to look at the fetal eyeballs, the globes, and the orbits, right? And how do we see it? We see it as two cystic structures ensconced into the orbits on either side. And we see the posterior capsule of the lens, and this must be documented. When we do this, we hardly take a couple of seconds. We make sure that the orbits are equal in size on either side, and there's place for another orbit in between the two orbits. This is the frontal approach to the fetal orbits in the axial or in the transverse plane. But when I go to the lateral approach, the lens looks a little different. We'll come to that in the next slide. And in the coronal approach, you can see the entire lenticular rim as two rings that you can see on either side. Those are the two orbits. This is the nasal cavity. This is the oral cavity. You can see the tongue within, and this is a bit of the mandible that you can see here. And this is an oblique approach, right? So when we look at the lateral approach, as I said, you don't see the lens as a posterior capsule streak. You see the rim of the lens as two specular reflections, the posterior capsule of the lens and the hyaloid artery. Mind you, this is a 21-weeker, so hyaloid artery is pretty much normal at this particular stage of pregnancy. If we wish to, we can look at the eyelashes. You can see the eyelashes of the fetus here, and here you can see the conjugate movements of the eyeballs on either side, and that becomes more frequent as gestational age advances. Now, is that all we can see? No, we can see more, but we don't do that more on a screening basis. But if indicated, if there are findings which demand a detailed study of the orbit, you can use the high-frequency probe, and we can look at details like the upper eyelid, lower eyelid. That's the palpebral fissure. So this is a sagittal section. And when I magnify it, those are the eyelids. You can see the cornea within, the anterior chamber, the anterior capsule of the lens, the posterior capsule of the lens, and of course the posterior chamber out here. And in the coronal, as I graze through the eyelids, you can see the upper eyelid, lower eyelid, and you can see the entire palpebral fissure out over here, right? So remarkable details that you get when you use a high-frequency transducer. And also to remind us of the fact that the retrobulbar component also can be seen in antenatal or prenatal ultrasound. That's the fetal globe. This is the retrobulbar chamber. This is the retrobulbar compartment. You can see the medial rectus, the lateral rectus as hypoechoic or dark stripes. And this, of course, is the optic nerve. And you can see the retrobulbar fat acting as a bright contrast, showing up the muscles and the nerves that we can see. And you will see the eyeball moving real time as I'm playing this clip to you. So we can go intracranial, and a part of the ophthalmic apparatus, neural apparatus, is the chiasma. So here you see axial section of the fetal suprasellar cistern, and you can see the optic chiasma there, and you can even see the optic tracts taking off. And once you see the chiasma like this, you can go ahead, measure the chiasma, and you have reference charts, right? Turn the color Doppler on. In the slow flow, you can see exquisite depiction of the fetal orbital vasculature. You can even see flow through the hyaloid artery. It's amazing just to see the amount of detail you can now get using technology. And once you see the orbits, you can measure. That's the orbital diameter. That's the inner orbital distance or the interorbital distance. This is the outer orbital distance or so-called binocular distance. MRI is the other way you can look at the fetus. And in MRI, the highlight on T2 weighted imaging is the fact that the lens is seen as hypo-intense, and it is actually contrasted very well by the hyper-intense vitreous that you can see. That's axial, that's coronal, that's sagittal. And in all these views, you can see the lens very, very clearly. And we'll see how you can actually exploit this in select situations. So why you need to study the orbits in particular? You know, as a screening, we do it. But in particular, do you zoom down on the orbits? Yes, under 3 circumstances. Of course, when you have an abnormality on a routine examination, as a part of the mid-trimester anomaly scan, you're going to go and zoom in onto the orbits. If you have seen some findings in this fetus, for example, a holoprosencephaly or a lissencephaly, I'm going to be interested in seeing what is the orbital status. I'm going to especially look for the orbits. And lastly, if there's past or family history of an orbital anomaly, ocular anomaly, I'm going to look at the orbits and the eyeballs in particular. So let me start. I'm going to run you through a set of conditions which can be potentially diagnosed in the fetus using ultrasound and, of course, complementary MRI and so on. So let's start from anterior and move posterior. The eyelids in ichthyosis are everted and become edematous. We call it ectropion. And in ectropion, you will see the edematous everted eyelids here. That's the nasal bridge in between. And when I do a 3D, you find the edematous ectropion out over here, and also the other signature, a very fixed, rigid fish mouth. You can see the tongue within, and this is congenital ichthyosis, a skin disorder. So classical signs of the eyelid in congenital ichthyosis. Hypertrichosis. I spoke of seeing the eyelashes, and sometimes the eyelashes are very, very prominent and long. You can see the fetal eyelashes there. That is cynophorous. The eyebrows are continuous, side to side, cross the midline. The eyebrows, this is called cynophorous. This fetus also has a septal agenesis. It has a complex cardiac anomaly, and it has a hooked index finger. All of them put together add up to Cornelia de Lange syndrome. Here is a dactyocystocele, classical medial to the medial canthus. That's the orbit. Medial to the orbit, we have a cystic structure seen in the late second trimester and third trimester, and that is a harmless thing unless, of course, it extends into the ipsilateral nasal cavity and causes obstruction to the airway. Now, cryptophthalmos, we don't go around snooping for cryptophthalmos in every case that I see, but here is a case where the lungs are huge, humongous. The trachea is dilated, bronchi are dilated. So I know that this is a congenital high airway obstruction sequence. I then look at the genitalia. The genitalia are ambiguous. It neither looks like a male nor like a female. And I look at the kidneys. There is a kidney disorder on one side. And I look at the foot. I'm not very convinced about the syndactyly, but with this combination, I'm thinking of Fraser syndrome. Fraser syndrome is an autosomal recessive syndrome, and therefore I zoom down, look at the orbits, particularly the eyelids. The eyelids are running continuous. This is a sagittal section. The upper and the lower eyelids are running into each other. I don't see a palpebral fissure, and putting everything together, we suspected Fraser syndrome. We did a whole exome sequencing, and we found that the FRAS1 gene is positive. It's homozygous in dose, and therefore it's autosomal recessive, a classical Fraser syndrome. Of course, this lady conceived again, and she has a normal child after this. This was, of course, terminated. Now let's look at congenital aphakia. Here is the axial section of the two eyes, but try as I might, I'm unable to locate the posterior capsule of the lens, and this is the importance of protocol. We need to know that I have to show the lens in every case. I fail to show the lens. And of course, another clue is that there is an asymmetry of the size of the eyeballs, big, small. So ophthalmos over here, I confirm it with MRI. There was no hypointense lenticular recurrence in this fetus, and she opted for termination, and we did an autopsy, of course, showing that from posteriorly, there is no lens, there's no zonule there. I can see the iris and the inner surface of the cornea out here. Congenital cataract is when there is thickening of the capsule of the lens, or the entire lens becomes hyperechoic. It's supposed to be lucent. Only the capsules are seen. Here, the entire lens is hyperechoic. And we know it could be due to infections, aneuploidy, inborn errors of metabolism. drug teratogenicity, so on and so forth. But remember, in a classical mid-trimester phase, cataract may not be always evident. So that is why if I've documented normal lens, even if this cataract develops later in pregnancy, I can go back to my pictures and tell the world that I've looked for the lens, there was no cataract at this point of time. Anophthalmia, microphthalmia is a small bulb or a small globe, and therefore the two sockets, the orbits are going to be small. There's a lot of soft tissue inside, a little small orbit over here. And in this case, it's bilateral. Here is a second-degree consanguineous couple, uncle-niece marriage. She comes with a red flag. She had her first child with bilateral microphthalmia, and this is a repeat for her. So no, we know that this most probably is an autosomal recessive condition, and therefore we have to go molecular in this case. Of course, she didn't get her molecular diagnosis done. That is the abortus. Right, here is a unilateral microphthalmia. The other orbit is normal. It can be unilateral as well. And then we move on to another case, bilateral microphthalmia. But in this case, hemivertebra, as well as intestines which are dilated. So this could be jejunal atresia and a Strom syndrome. Those are normative charts for the bulbar or the orbital measurements. Lastly, before I let you off for the discussion, persistent hyperplastic primary vitreous, also known as persistent fetal vasculature. We know that the hyaloid artery involutes by 30 weeks. So if I see the hyaloid artery in the fetus after 30 weeks, that means there is persistent fetal vasculature. And we all know that it can cause retinal problems in terms of detachment, bulbar hemorrhage because of the presence of tunica vasculosa lentis. And here is one such case that is a 34-weeker. And you can see at 34 weeks, there's no business for the hyaloid artery to be seen. On one side, it is seen. And on the other side, there's a traction retinal detachment that you can see here. That is the traction detachment in another picture of the same case. And this is a thick posterior capsule telling us that there could be a tunica vasculosa lentis. And we got an MRI done. Of course, before MRI, I used a high-frequency probe. That's a 12 to 5 megahertz probe. You find very well seen compared to the lower frequency probe. You can see the exquisite detail of the traction detachment and the hyaloid artery, which is thickened, going on to the posterior capsule of the lens. And this was confirmed by MRI. You can see the traction detachment, the hyaloid artery, not only on one side, but on the other side as well. But here, this was not supported by other features of Norris disease. This was Norris disease is X-linked recessive, and therefore in boys. And we have, together with the ocular findings, we have IUGR, we have a depressed nasal bridge, large ears, so on and so forth. Nothing else was really forthcoming in this particular case. So I break for discussion. I'm sorry I have overshot by a couple of seconds. Thank you so much. I stop sharing. Over to you, Dr. Ken.
No, thank you so much. That's fantastic. So while everybody sort of gathers their thoughts, because I'm sure many of the discussants won't have seen images like this, but I've been privileged to listen to Dr. Rama Murthy previously. Any thoughts, initial thoughts? Rita, Louisa, Hannah, any questions that you would like to ask Dr. Rama Murthy? And also, we can also pull in Dr. Mankad in a minute, and of course, Ramesh. So any questions from the discussants?
Well, first of all, a comment. What beautiful images you brought, and with such an amount of detail. It really makes a safe diagnosis, I believe. So I'm amazed with all the detail on these images. I would like to ask you, Dr. Murthy, so you do the MRI when there's something that is associated with the orbital diagnose, or if you have just a suspicion of microphthalmia or something, do you do MRI?
I think for a microophthalmia or an anophthalmia, if it is gross, we don't need an MRI. If the orbits are obviously small, and even subjectively, I know that they are small, so I'm not going to go objective. I will, for my report's sake, I will measure the ocular diameter. But the problem comes in borderline cases. You feel it is small, but it's not all that small. I'm on a sticky wicket over here, and that is when I take a measurement. I leave an interval, come back to me after 2 weeks. I'm going to remeasure and see if the growth is there. If the interval growth is not there, I'm going to press a panic button. And in those cases, yes, perhaps I might do an MRI, because MRI also can do biometry. I can corroborate what I have seen on MRI as well. Not in obvious cases, but borderline cases, tough cases, yes, perhaps MRI would help me.
Let me ask a question of everybody on the panel, right? So as clinicians that are pediatric ophthalmologists, how often have you, Rita or Hannah or Ramesh or Louisa, asked for a fetal ultrasound specifically for one of your cases, or one of your families? Have you done that before?
I haven't.
Louisa?
Me neither. But what I do
So-
ask sometimes for the families, for example, the ones that came for unilateral microphthalmia or any other condition, is if it was diagnosed during pregnancy. And the answer of like almost 100% is that it was not.
Right.
Absolutely. I have that also. I agree.
So, I can say that in my entire career, there's only been 3 occasions where I've specifically said, can we have a look at the fetal ultrasound or fetal MRI? And I think the discussion will become clear. There are many people asking questions about when do you do fetal MRI rather than fetal ultrasound. And I think towards the people who are asking those questions, we'll be able to clarify those as the webinar goes forward. I just want to bring in Dr. Mankad. Dr. Mankad, at Great Ormond Street, most of the fetal ultrasound wasn't actually done when I was there, which is over 12 years ago, at Great Ormond Street. It was actually done, a lot of the prenatal diagnosis was done at King's, because they had a couple of characters there who were really pushing fetal medicine. What's the state of fetal ultrasound now in terms of prenatal diagnosis at Great Ormond Street?
Right. I think the only thing that has changed, not just at London, but across the world, is the lower threshold to switch to MR as soon as any remote abnormality is detected on the ultrasound. And I think where we kind of differ from probably what Dr. Rama Murthy has said is that if you do pick up a barn door microophthalmia or anophthalmia, all the more reason to pick up syndromic changes in the brain and the rest of the study, which will actually point towards prenatal genetic diagnoses. And I think that will be really complementary in terms of looking at the brain and checking what is happening in the eyes once again. So, there is a very much lower threshold, and a lot of patients, not just in the UK, but in neighboring countries in Europe and the US, a much low threshold to do an MR, and in fact, repeat the MR scan as well once we kind of do not know exactly where we are headed to with a particular diagnosis. Whilst prenatal genetics is happening in the background. So there's a lot of impetus in that direction. And I think it mitigates the risk of newborns with obvious problems of dysmorphism in the brain, which was not picked up on an ultrasound, which was done at 20 weeks, for instance.
Ramesh, of course, Dr. Murthy, please.
Yeah, I very well appreciate what Dr. Kish has just told us. And in my last slide, I'm going to say that any orbital pathology should be supported by a dedicated fetal neurosonogram. And today, our pictures are so good of the brain that we have enough evidence that if you do an MRI after a dedicated fetal neurosonogram is normal, you hardly pick up additional findings by MRI to the tune of about 1 to 5%. So in about 95 to 99%, we guys with ultrasound are able to see the brain exquisitely well. And of course, again, I must say this is not an ultrasound versus MRI. It is ultrasound complemented by MRI. And in the fetus, the sheet anchor of imaging is indeed ultrasound. And then, of course, we move on to MRI.
So my question is how do we get more people like you who are so good at ultrasound, fetal ultrasound? I mean, you know, that's the big question. How do we get people to train like you? Because you know, fetal MRI, definitely, I've come across more fetal MRI because I think it's, in some ways, my impression is it's easier to do and to interpret, because I think ultrasound takes a certain amount of learning curve. Now, I want to bring Ramesh in. Ramesh, how often do you use fetal ultrasound? Do you ask for it?
Yeah, again, thank you so much, Dr. Ramamurthy, showing that spectrum of cases. Sometimes I didn't even know this was possible. So typically, again, I have not advised too many patients unless the patient has a typical cryptophthalmos or anophthalmia. There is a family history of that. Then I have asked. In one patient, I have even got the positive finding in the ultrasound. Again, the specialist, what we have in India, like Murthy, will be very less. So we'll have to send them to specific places, then only we get it. If you ask me a number, it's less than a dozen or so. But the positivity, I would have gotten maybe 3 or 4 cases.
Okay, we need to move on, but I just want to mention a couple of things. Somebody's asking about the prenatal diagnosis of retinoblastoma, and I'm going to, if we can perhaps discuss that in the next discussion or later in the webinar, but we will cover that. Just to say that we now have people listening from the Ukraine, Chile, France, Italy, Brazil, Kenya. It's becoming a very, very global webinar. So on that note, Ramesh, I'm going to hand it to you to ask Dr.
Thank you. Thank you, Ken. We'll have the second part of Dr. Ramamurthy's lecture. Over to you, Dr. Ramamurthy.
Let me share my screen. Okay, so is my screen seen, my arrow moving?
Yes.
Yep.
So we'll move on to the second installment of this presentation, and this is going to be much shorter than 12 minutes. Let's hope I can make up for what I've lost. Retinochoroidal coloboma, because all of us know that this is due to incomplete closure of the choroidal fissure, and it's important to know that the choroidal fissure or the optic fissure is completely closed by about 35 days of conceptual age. This results actually in a scleral outpouching. You can see the globe, you can see the posterior capsule of the lens, and out here, inferomedial or inferonasal, you have a narrow neck and a diverticulum-like structure, which is coming out into the retrobulbar fat, and that is a retinochoroidal coloboma. It's usually bilateral, and it's got a great genetic overlay, and you have a lot of syndromes in which the retinochoroidal coloboma can occur. And of course, this is the MR. This was the first case and the only case I've seen in about 34 years of my practice. And on MR, what is important is the bilaterality was really revealed. This one I picked up, right? Very well seen, the same pattern. You can see the same kind of picture, but on the other side, there is a tiny little one which I failed to pick up by ultrasound, right? So this is a bilateral retinochoroidal coloboma. Moving on to retinal dysplasia. Now, we spoke of a traction displacement with the apex of the displacement being anteriorly pointing, but here is a retina which is thick, which is attached at the ora serrata, and which is actually tethered to the optic disc. And therefore, this is a dysplastic retina which has detached from the underlying choroid. this is a sagittal section or a coronal or a transverse section, whereas this is a coronal section where you can see the entire thick retina has separated out from the underlying choroid. So that is retinal dysplasia and retinal detachment. And in this particular case, look at the intracranium. The intracranium shows you bilateral lateral ventriculomegaly. And of course, this is a 25-weeker. And at 25 weeks, I don't see the lateral fissure at all. There is no sylvian fissure. There is no parieto-occipital sulcus that I can see here. The pial surface of the brain has a hyperechoic layer telling me that there is overmigration of neurons. And this is classical of cobblestone malformation. Look at the pseudofusion across the midline. I don't see the fox cerebri posteriorly at all. There is nothing. There's pseudofusion happening over here. Everything telling me that there is a lissencephaly, there's a cobblestone malformation, and with a retinal detachment, I'm going to think of Walker-Warburg syndrome. And of course, the trademark is on a mid-sagittal section, you get a Z-shaped or a kinked brainstem, a classical Walker-Warburg syndrome. And moving on to positional abnormalities, hypertelorism is when the orbits are inordinately far apart. There's more than one orbital space in between. And the cause for this case of hypertelorism is clear. You have a frontoethmoidal meningocele or an encephalocele, which has come into between the two orbits, pushing them apart, right? And in the same case, you have a median cleft lip. So this is a median cleft face syndrome. It can occur in hypertelorism, can come in a lot of skeletal dysplasias as well. Now, hypertelorism is the other way around, where the orbits move closer to each other. There's not enough space for another orbit intact, indeed over here. And then, of course, we know that this is common in a lobar holoprosencephaly. You find a primitive monoventricle. That is the hippocampal edges, and this is the communication between the dorsal cyst that we can see here and the primitive ventricle, monoventricle. Note that this is a cup-shaped holoprosencephaly. There is no Fox echoes, there's no corpus callosum, nothing whatsoever. Total non-cleavage of the prosencephalon associated with hypotelorism. Here, I would like to say, both in this case of hypotelorism as well as in the Walker-Warburg syndrome, we didn't start with the orbit. No, we started with the brain, and the findings in the brain really pushed us to look at the orbits, not only as a part of the mid-trimester anomaly scan, but also because there were intracranial findings which really prompted us to look for certain associated findings in the orbit as well. Now, extreme hypotelorism is when the orbits run into each other. This is called cyclops, and this is classical proboscis that you can see on ultrasound. And on the eubottis, that is the midline cyclopia. There's no nose at all, and that's arrhynia. That's one case. Here's another case at 24 weeks. This is at 19 weeks. This is at 24 weeks, showing you a cyclops, arrhynia out over here. A single eyeball, a single midline lens that you can see as well. Exophthalmos protruding eyes could be due to 3 reasons that we can recognize on prenatal ultrasound. A large globe itself can protrude, as you can see here. Normal size, large eyeball, that could be due to ophthalmos, or it could be axial myopia, as happens in Marfan syndrome. It could exophthalmos could be seen in craniosynostosis due to a shallow orbit, or it could be due to a retrobulbar tumor, most often a teratoma, which is pushing the eyeball forward. And of course, this is an example. This is the only example. It's a very old case that I have. We'll see the orbit on one side, normal, and on the other side, there's a complex mass, a cystic solid mass. And after birth, you see the entire eyeball is out, and a CT scan reveals a large retro. That's the bulb, and behind the bulb, There is a large solid and cystic mass that you can see here, a lot of calcification happening out there, and that's a retrobulbar teratoma, which is actually pushing the whole eyeball out. Lastly, a few miscellaneous. Now, here is the intracranial finding again of septal agenesis. I can see the anterior, I can see the interhemispheric fissure. I can see the cingulate gyrus beautifully formed on either side. I can see the corpus callosum, but the frontal horns are running into each other. The cavum septum pellucidum or the septi pellucidi are not seen. And in septal agenesis, we have to look at the chiasma because you're worried about septo-optic dysplasia. And in this fetus, the chiasma was very, very small and it was stubby. We've got fetal charts for the optic chiasma as well. So we said that this is possibly a high risk for septo-optic dysplasia. This is the baby after birth. The baby's visual acuity to date is good, but it's got endocrine problems. It's receiving growth hormone injections from on the advice of the pediatric endocrinologist. And what about 11 to 14 weeks? We all through spoke about 18 to 23 weeks, but let's go earlier in pregnancy. Let's look at the other window. That's the 11 to 14 week scan, where we call it a first trimester anomaly scan, not a mid trimester anomaly scan. And these are normal cases. On transabdominal, you see the two orbits, you see the two lenses, you see the two orbits and lenses. That's the premaxillary triangle. That's the metopic suture. Those are the frontal bones. And on transvaginal study of the fetus, you see the orbit almost like the second trimester, including the posterior capsule of the lens. So in the process of doing that, you can pick up pathology. Here is a transvaginal view of a 12-weeker perhaps, showing you the bulb. That is the eyeball. But there's something protruding out from the outer corner. That's an epibulbar dermoid. And in the same case, I could pick up at 12 weeks pre-auricular tags. I have not put those pictures here for want of time. Pre-auricular tags, epibulbar dermoid, and that combination tells us that we are possibly dealing with a case of golden hour syndrome. I showed you a case of Walker-Warburg syndrome in the mid-trimester. Here is a case of bilateral ventriculomegaly as early as 12 weeks or 13 weeks. You have huge ventricles. The choroid plexus is rather discrete and small, telling me that these ventricles are pathologically large in the first trimester. And when I look at the orbit here in the first trimester itself, these are transvaginal pictures. Let me stop this. You will see that the lenticular echos are very, very thick. The posterior capsule echos and the hyaloid artery is very, very thick for the first trimester. It's supposed to be a very delicate structure. So I know ocular findings with bilateral ventriculomegaly, obliteration of the pericerebral space tells me that I am dealing with a Walker-Warburg syndrome again, which is a alpha dystroglycanopathy or dystroglycanopathy. And we have a geneticist with us who will take us through all these pathologies. So to conclude, study of orbit is an integral part of the mid-trimester anomaly scan. Standard planes of section are to be documented. This enables recognition of a range of conditions. Prognosis is variable, of course, depending on the condition. And you people, pediatric ophthalmologists, are going to take charge of counseling. Some conditions are associated with blindness. Some are associated with grave intracranial pathologies. This is why we need to do an extended fetal neurosonogram for every case that we see where the intracranium is not the leading finding. I've seen something in the orbit. I've got to go back and look at the brain beyond the basic axial sections. I need to take the help of MRI whenever I feel it's needed. And ocular findings plus other findings may suggest a syndrome. We saw a case of golden hour syndrome, Fraser syndrome, Walker-Warburg syndrome, Strom, so on and so forth. Geneticist, extremely important, three generation pedigree chart. What is the kind of testing we're going to do? If I'm going to do an amniocentesis, is it a chromosomal microarray? Am I going to offer an exome sequencing? And of course, counseling by a pediatric ophthalmologist. The gist of the fact of the matter is that this should be a multidisciplinary approach. Fetal medicine specialists, radiologists, obstetricians, geneticists, pediatric ophthalmologists, neonatologists, who come together and try and help this couple in cracking the diagnosis and giving them targeted counseling, and they can make an informed decision. Thank you very much. Jai Hind.
Thank you so much. That was a real tour de force. Thank you. Wonderful, wonderful talk. So much to talk about, so much to think about. Before I start discussing or asking the questions from the YouTube channel, I just want to say we now have had people who have joined us from the Crimea in Russia, Honduras, Mexico, and Romania. So a lot of people congratulating you on your talk. So can we just, between you and Kish, can we just ask, what is the role of prenatal diagnosis in retinoblastoma? Do we do that? I mean, if there's a family history, do we do prenatal ultrasound for the worry of a retinoblastoma?
The problem with retinoblastoma is that the tumor size is so small. It might beat the resolution of our machines. I think we have our geneticist with us. I think the prenatal diagnosis, in my understanding, is more genetically driven rather than ultrasound driven, because if I say ultrasound wise, there's nothing in the retina which is looking like a mass. I'm being very gross. I'm not going to find out those small little foci of tissue which could potentially be malignant.
Of course. Kish?
I would concur. I think if there is, in fact, I have a case in my presentation as well, but they are rare, first of all, and rarely made diagnoses. But if there is a germline mutation running in the family and the risk is high, I think we do pay special attention to screening them as adequately as possible antenatally. But I think it is just an incidental finding in most cases. But of course, the risk in the background needs to be taken into consideration. But they are very small, and the case I'm going to show to you is a little nodule, and the final diagnosis was confirmed only postnatally.
And if I may, I was going to say, if I can add to that, yeah. The advantage of a prenatal diagnosis for retinoblastoma really only comes when that family history is already known, as you mentioned, because the tumor is so small. And then some of the guidelines that have been created, if you do have the ability to do prenatal testing, prove that the fetus has, do you consider early delivery by C-section up to 4 weeks early, so that if the tumor has begun to grow, that you can get the advantage of the earliest treatment possible to save as much vision as possible.
So knowing the person who asked the question, he's from a country where genetic evaluation and prenatal genetic testing is not necessarily very easily available, and I think that's where the question was coming from. But we'll see what Kish presents, and we can talk about that later. So, Hannah, what Dr. Rama Murthy and Dr. Mankad tell their patients?
These conversations are often happening in the obstetrician's office, because the second trimester anatomy scan is fortunately a common procedure that's being done. So genetic counselors, we don't meet these patients often until after that scan is done and has found something. So the opportunity for counseling really is in the hands of the prenatal providers, the OBGYNs. And the role of a genetic counselor often comes right after that moment. But there certainly are very important discussions to be having, but they're often only had once the anomaly has been identified.
So Ramesh, please do inject. I'm just going to give a real world example that happened to me recently, where we had examined a girl, I think she was a 6-year-old, and it was noted that the girl had sutural cataracts, and that was it. The mother was examined. The mother also had sutural cataracts, and no other implications were considered. And the child had come for a screening. Then the mother became pregnant, and I got a note saying, mother would like you to see the prenatal ultrasound. Because the prenatal ultrasound was that the child was a boy, and they had picked up bilateral cataracts. So I'm going to switch this. So if you've got a boy with bilateral cataracts, and the mother got sutural cataracts, and the sister has got sutural cataracts, that's Nance-Horan syndrome till proven otherwise. Right? That's a carrier status. So let me ask you, if you see something, Dr. Rama Murthy, do you, on the scan, do you say, send a message to, let's say, Dr. Ramesh and say, I think it's worth examining the siblings or the parents to see if there are any carrier signs for this condition that I am suspecting? Do you do that? Should we do that?
Absolutely, because my knowledge of ophthalmology is bare minimum. It is just an existential living for me. I've picked up a coloboma. I do not know. I know there's some outpouching, but I'm going to tell my patient, hold on, not going to give you the report today. I have a finding. Let me see what it matches up with, and I'm going to go and learn about the coloboma first, and then I'm going to spell it out. I don't know what is a coloboma until I see it. And having seen once, the first time, I need to read about it. And once I know that this is the diagnosis, I'm going to put the case across to a pediatric ophthalmologist. And the pediatric ophthalmologist will take care of the rest.
Gish, how closely do you work with a pediatric ophthalmologist at Great Ormond Street?
Oh, very closely. But of course, it's not an ultrasound-led service. So if any incidental finding is found, in fact, they are generally there before we even call them. And okay. close defense of my amazing colleagues, they're very good with the radiology as well. And they know kind of the pretest Bayesian principle of what might be expected from the scan. So they're literally at the door when the scan's done.
Fantastic. Any questions from the discussants? Ramesh, Louisa, Hannah, Rita?
Yep, I do have one. Dr. Rama Murthy, when you are doing the ultrasound and you do identify an orbital anomaly, does the gender of the baby then influence where you look next, extraorbital? And could you give us some insight on that?
Because yes, if it's a X-linked recessive, for example, Norris disease is X-linked recessive. So immediately I'm going to look at the perineum and look for the genitalia. If it's a girl, I would say unlikely to be a Norris disease. Similarly, for Fraser syndrome, I'm going to look as soon as I saw the hyperinflated lungs, I said I'm going to look for syndactyly, I'm going to look for cryptophthalmos, and I'm going to look for ambiguous genitalia. So I went to the genitalia, and true enough, I found a stubby little microphallus and not much of a scrotum there at all. So the genitalia were ambiguous, and therefore, certainly, yes, in X-linked conditions, genitalia do help us to narrow down the possibilities.
And I think that's so important to consider because genetic testing isn't always available, or the family elects not to proceed with the genetic testing if it's offered. And so taking that extra step as you are to kind of look to see, could I get any more information about possible inheritance patterns, get down to a clinical diagnosis, as difficult as that is through fetal imaging, still is a step forward when genetic testing is not opted for or not available.
I've got two questions that have come in, and I'm going to open them to the whole audience, but obviously, to the whole panel, but obviously, Dr. Rama Murthy and Dr. Mankad, if you could take them first. First question is, Naomi, I hope I'm saying this right. Naomi Corbin says, is it possible to prenatally do ultrasound diagnosis for hemimegalocephaly? And then third cranial nerve palsy and consider CVI. I don't know. I don't understand that last bit. But so for hemimegalocephaly, I presume that can be done.
Yes, hemimegalocephaly can be prenatally diagnosed because when you look at the axial section, one of the things is to look at the symmetry on either side of the midline structures of the cranium. So if one side of the cranium, one half hemicranium appears large, the other one is smaller, we go for an extended neurosonogram and we look at the difference in size of the two hemispheres. And in hemimegalencephaly, more often than not, the bigger hemisphere is the pathological hemisphere, and you have sulcational abnormalities on that stage. You have heterotopias occurring. So you have corroborative evidence on that side to say that this is prenatal hemimegalencephaly. Yes, we can diagnose.
So, Naomi, if I got the question wrong, please re-put the question in, and I'll clarify it. So that was great. And then Savlin Kaur asks, if we find something in the first prenatal ultrasound, is it advisable to wait for another ultrasound at a later time for an 18 to 33-week scan, considering the risk of termination to the mother if termination is an option?
Yeah, that is on a case-to-case basis. If your diagnosis is clear, for example, I saw cataract and I saw ventriculomegaly in that first trimester fetus, and I found the brainstem was kinked. It was a Z-shaped brainstem. I need no more evidence. I know this is Walker-Warburg syndrome. Straight away, I would say go molecular, do your mutational analysis, go for an exome, show whether it's POMT1 or whatever, what are the genes that are involved, and then you have the option of terminating the pregnancy, because it's a horrendous thing. Walker-Warburg, the outcomes are so poor. So they would decide immediately on the basis of first trimester, backed up by a molecular diagnosis. Whereas sometimes you get a diagnosis only in third trimester, like, for example, persistent fetal vasculature. Perforce, you have to wait till 30 weeks and beyond if I have to diagnose persistent fetal vasculature. There's no way I can do a first trimester diagnosis and say, okay, this is a persistent fetal vasculature. That's normal. That fetal vasculature is normal at that stage. So it's on a case-to-case basis. And as I said, microophthalmias need not be an all or none phenomenon. It is graded. It has got a spectrum. You can have severe, you can have moderate, you can have very subtle. So you need to look at serial measurements. And lastly, cataracts need not always present in the mid-trimester. I have done a mid-trimester anomaly scan. I've called the orbits normal, but in the third trimester, a cataract is seen. So that is where documentation is extremely important. I can go back, open my pictures, and convince myself, convince the world that in the mid-trimester, this lens looked normal. And that's the power of documentation. Also, I'd like to point out again that when we say there's a cataract, it is a sonographic sign. I'm not commenting on the optical property of the lens at all. I'm commenting on the sonographic property of the lens. So that means to say, even if I don't see a cataract as a thick posterior capsule, I'm not telling this couple that there is no cataract. There's no cataract in a form that I can pick it up. There could still be cataract because ultrasound does not deal with optical property of the lens. It only deals with the... Yes. Yes, I hope I'm
going to hold it there for a moment. There are lots of good questions, but I think we need to move on with the webinar. So Ramesh, I'll ask you to introduce. But this is, I can't tell you the feedback at the moment. People are just completely blown away by what you are able to do. And I know once they listen to Kish, it's going to be the same thing. So let's go on to the next section.
Yeah. Thank you, Dr. Ramamurthy, for the beautiful presentation. I think, unfortunately, we have to stop now and move on. I request Dr. Kish Mankad to deliver his talk on MRI. And most of the questions will be, I think, answered after his talk. Over to you, Kish.
Thanks, Dr. Ramesh. You have made it an MRI talk. It is going to be multimodality, I hope, just like the real world around us should be. But this is going to be a little bit more reflection, less words, more provocation, and multidisciplinary in its own way, which is how the practice of this very complex field should be. And I think apropos to the World Health Organization theme this year for patient safety being, get it right, make it safe. So whatever we have in terms of detection and in terms of enhanced diagnosis that follows, relevant to the resource setting that you're practicing at, as well as the clocking time in your background, I think there is a lot you can do before getting that diagnosis completely right and making a safe, prosaic diagnosis for the benefit of the child who's not yet born, as well as the anxious parents and the family in large. And that is kind of the essence of these few cases that I will break down into 3 parts so we can have some discussions as well as provocative thoughts put together and then move on to some other themes. So first of all, just the basics on MR as well as ultrasound, go looking for it. Is the eye present? And if it is, are they bilateral symmetric? And if they are bilateral symmetric, are they looking appropriate in terms of their size and some very basic metrics, which Dr. Rama Murthy has already talked about, and it could be totally extrapolated to MRI with a little more clarity, if I may, with a pinch of salt, add that in certain situations where ultrasound is a very, very operator-dependent modality. Not always easy to do a fetal MR in itself because we have a very moving target, but I think there is a lot being done in that space, and we hope that MR technology will continue to improve and remain overall safe for the mothers and the baby. Once we have got that out, we start looking at some numbers and metrics, and we decide where we are with fitting that little orbit into the middle space between the orbits, very nicely shown by Dr. Rama Murthy, and then determining if we're dealing with a hypertelorism on the go or a hypotelorism. And once we have got that, we have the charts to assist, we have a list of differentials to consider in both these verticals. This piece is not about trying to cram up every possible differential diagnosis. This is about giving you an overview and something to go home with or switch off from the YouTube that you're listening to in terms of once I have found it or once I have not found it, as in the case of anophthalmia, what should be the triggered pathway in my head going forwards. Once I have determined they are small, are there any additional findings? 2 different pictures from the same patient showing a cluster of possibilities there and a few differentials that go on. And you can see that very soon we are moving into the genomics of this, as well as the chromosomal aberrations that we need to be aware about and the syndromic associations that go with the discoveries. So if you've seen the eye, go to the brain. If you've seen the brain and you picked up a malformation, go back to the eyes. It still remains that the eye is the window to the brain and the face predicts the brain. So that has not really changed in our practice, whatever modality you're dealing with. 3 different cases for this first part, and the theme of this is cystic masses. So we are straying a little bit outside the brain, but we have to ensure that we look at the brain in all these cases. This is my first case. It's an Irish family from London, and everything I say is relevant because the number of words on my slide will be quite limited. And once I mention the word Irish family as well, or particular parts of the world, you need to be completely cognizant of practices, of beliefs, as well as the legalities around putting a diagnosis together, which could be quite catastrophic. So it's a sensitive and a time-sensitive issue. So this was preceded by an ultrasound discovery of a large cyst and proptosis, as you can see. T2 weighted sequences, the mainstay of fetal imaging, and particularly if we can get a good axial and a good coronal, I think we should be able to make a pretty good diagnosis of what we're looking at. So this is a cystic orbital mass. That is where the eyeball is lying, and you can see that it is quite homogeneous in its texture, so to say, with maybe one little septation on each side. But overall, very, very homogeneous, very cystic. And we could scroll this if required, but I can tell you that there was no communication with the intracranial compartment. And at the age of 27 weeks plus 3, the folding of the brain was normal, and the associated neuraxis did not show any abnormality in there. So you're left with the cystic orbital mass. What are you going to do? And whilst you're thinking about the possibilities, I'll tell you the real world possibilities that did come into motion here. And we're dealing with a parent who's anxious. You can see there's a mother in question. Should we deliver now? It's 27 weeks. The maturity of the brain is okay, not bad. The brain is not damaged. Should we consider an amniocentesis? Should there be an aspiration, decompression? In fact, the initial diagnosis of this from the preliminary center was that of a lymphatic malformation. And if a lymphatic malformation was considered, then parents, and any parent would have the obvious layman question, why not just decompress it and let the child go to maturity and deliver them? Or do you think this is some kind of a tumor or a neoplasm which is going to get worse and fill up the whole space, and should we consider termination right now? But we are at 27 weeks. And yes, we are an Irish family. Or should we just scoop out every content right now, do an exit procedure basically, and see how things are? And these were the discussions that I was having on one end of a Zoom call like this with the ophthalmologist, Dr. Gore, at the other end, parents probably in Oxford, and a center outside of London. So like 5 or 6 people from different disciplines, including fetal medicine, just trying to understand what should be the right pathway. And sometimes, and most of the times, you might not instantly know what the right pathway is. So our role doesn't just stop at detection and trying to give a dogmatic conclusion to our report. To keep it adequately open and to actually go back and speak to the families along with amazing clinicians like yourself is value added in 2024. The plan was to repeat the scan, and at 36-week gestation, the scan was repeated. So first of all, the brain maturation was looking good for 36 weeks. You can see a lot more sulcation, etc., coming in there. And what has happened to the cyst? No, there hasn't been any aspiration, etc., because the pathologist said, even if you sent me a sample, I will not be able to differentiate between a lymphoma or a lymphatic malformation or a teratoma or a cystic rhabdo. It's impossible to tell from the fluid itself. We can give it a go, but if you miss it, that still doesn't mean we've got the right diagnosis. So we went with that. The pathologists were involved as well. A repeat scan shows a dramatic change in the morphology of the cyst. It is not homogeneous anymore, and there are lots of little elements which could be construed as solid or less cystic elements, and the overall proptosis is looking much better, and the brain is growing in the background. Now what? We are almost term. We are close to term. So things could be planned in a more kind of dedicated, controlled manner. This is where the ophthalmologists, the fetal medicine guys, and the obstetricians have a meeting again, saying, fine, let's proceed and let's deliver, because now we are in a safe place. This is what the child looks like. You've seen an example of this with Dr. Rama Murthy's presentation as well. And just to give the non-ophthalmologists in the audience listening in a purview of everything they say on the radiology report and how it translates to practice, not to scare you or show you something gross. At the University College London Hospital, my colleague Kelly Pavarotti, great neuroradiologist and does fetal medicine there, said, okay, let's do a day 1 at birth incubator MRI scan. So we managed to get some very basic sequences, but enough to say that there was heterogeneity in there. This is a T1 weighted sequence. What MR gives you is not just one plane or one sequence. It gives you multiple possibilities of playing around with those protons in the brain and giving you signals that can actually help you decide what tissue we are dealing with. And once you pick up a T1 shortening in the middle out there, your possibilities are distilled down to hemorrhage, anhydrous calcification, fat, melanin. And in the context of what you were initially calling a lymphatic malformation, you have switched the differential to a teratoma already. And then as time goes by, we said, let's wait a little bit more, 7 days, no intervention done yet. And this has shrunk even further. And we were able to get a proper MRI scan with much more sequencing as well as contrast. But the key bit here was the ability to suppress the fat out on a proper scan, and we pick up fat suppressed sequences demonstrating the fact that this is a teratoma. And probably because of watchful expectancy, masterful inactivity, lots of discussions, we were managing to mature this teratoma in the background. And the final histology was mature teratoma with no yolk sac components. So yes, all the contents were scooped out after that. That was not a functioning eye, so to say, but the contralateral eye was normal and the brain had not been infiltrated, which was very, very good news in all this despair in the background. 2 years on now from that story, and I just wanted to highlight, this is not the same child, but just to give you an idea of what changes for the family, giving the context of real world, is the fact that mother, this is from the notes in the clinic, the mother feels that This child is now ready to have a little bit more of cosmesis and improvement in the looks, because she is 2, but 2 is the new 12, so to say. And the child is beginning to notice the difference between the 2 eyelids, but overall, surviving, developing well, and we're going to do something good to make that eye look better. Lessons learned a lot, frankly. This was a difficult case, and I think the imaging does not do justice just to look at, oh, this is a great case or a startling case of something, but a lot of thought and thinking that goes behind these cases. And from our perspective, the importance of optimizing these sequences to make the most out of imaging. Companion case. Now, this is interesting. A friend from Chile who's probably listening and right now sent me this case just last night because I was looking for a companion case. And this child did not do too well. It's hard to tell the gestation from the folding of the brain because there is no normal brain tissue, as you can see. There is a lot of proptosis, and it is again unilateral on one side, most likely the right, but we have to ascertain that from most sequences. But the whole brain matter is essentially heterogeneous. And the first thoughts, even from the perspective at the local hospital, was probably a teratoma. But for some reason, this has been in the archives at the moment as a cerebral neuroblastoma. And that's a very difficult call to make in a diagnosis like this. So we have requested formal histology and a revision and a review of the pathology. Sometimes the added value of radiology would be to go back and question what has been picked up as round blue cell tumors, which is not what the general phenotype is. So we do beginning in the WHO age of revisions to the World Health Organization classification of tumors, question these diagnoses a lot more. But this child did not make it. It was a grim outcome. And this is a postmortem picture of what the heterogeneity of this mass looked like, quite hemorrhagic in its own way. An unfortunate end, but the pathology is still not clear. And sometimes you don't get it all clear. Moving on from teratomas and other suspected tumors, we are still in the cystic kind of area. Now, Dr. Rama Murthy showed a beautiful ultrasound scan, and I will show you an ultrasound scan as well of this entity. But the questions here were, is this an anterior encephalocele based on the ultrasound appearances? So we needed an MR to look at its communication with the intracranial compartment. And this is an early gestation scan where we see that there is dilatation of the nasolacrimal duct on one side with a large cyst, and the MR quite nicely shows that this is centered on the medial canthus without any intracranial extension, making thus a diagnosis of dacrocystocele easy. Dacrocystoceles, as you very well know, can also be called nasolacrimal cysts or lacrimal duct cysts, and are secondary to the fact that there is an obstruction to the nasolacrimal duct. They may be bilateral, they're commonly unilateral, and in this particular case, and as in most cases, the spontaneous regression could be in utero or within the first year of life. So this is a spontaneous regression in the same child of the dacrocystocele, and the ultrasound that preceded the MRI. Of course, the ultrasound savvy people in the audience would know exactly what the communications are, but unfortunately, the operator was not clear on whether this was an anterior encephalocele, and you can see why that differential might be so relevant. So once we have established that we have a limited differential to offer in terms of cystic masses, when you encounter entities like this, you have to think about multiseptated lymphatic malformations. And in the same way, when you think about lymphatic malformations, think about lymphatic malformations, which are a little more solid-like. So just kind of to complete that loop on cystic cases. Also cystic, yet in this case, this is of course a postnatal scan. The prenatal imaging showed a large developmental cyst, as it was called, and be wary of these developmental cysts because this turns out to be an optic nerve glioma in the context of NF1. Definitely worth the wait to give contrast, to see what it's doing and what its trajectory is in terms of ancillary findings. I want to leave you with a difficult case, a little bit of lateral thinking, and the whole idea of expecting the unexpected. So this is, again, a postnatal, very early scan. They were born with this swelling, and the swelling was there, and we did an ultrasound. It showed heterogeneity. A lot of differentials were put in, like vascular anomalies, etc. If you think about a vascular anomaly, then you start thinking about sclerotherapy and a different kind of trajectory. There was a bit of bluish discoloration of the skin as well. You might want to know that eventually it needed surgery, and Mr. Abu Raya, our ophthalmic surgeon, got this all out as a one piece. and that is the pathology specimen of this. I'm happy for you to read this slide if you want to, but the final diagnosis here was a heterotopic glial tissue. So that kind of completes the cystic to the less cystic possibilities and how maturation over time happens in these cysts. It's a dynamic phenomenon, and it can be captured clinically as well as by repeat titrated and tailored imaging. Sometimes the sequences could be kept quite brief to get the answers right. I'm going to pause. This was part one.
Yeah, thank you, Dr. Mankad, for that wonderful images. And what I like the best is you told the whole story about the patient, what are the difficulties and the complexities. And also you showed cases from 3 different continents. So it's really wonderful to have those cases. Anybody on the discussant, any questions at this point of time? One question I had was, typically an MRI setup, how long it takes to do the complete screening. You will have patients who are just for screening. You will have patients with the high risk history already. You know, in both of this scenario, how long it takes to complete your scan for a prenatal scan?
So we try not to do a lot of just screening MR. Once we have committed to a fetal MR, we try to do a comprehensive, at least the baseline evaluation of the brain as well as the spinal cord and looking at the body as well. The role of screening fetal MR is extremely limited. And of course, it depends on other factors like anxieties and other things. But we try to keep it quite comprehensive because only that would facilitate the right biometric evaluation of the fetus as well. So I would be very wary of using the term screening fetal MR for complexity that you're trying to define, which has been picked up on an ultrasound scan preceding it.
Okay. Anybody has any questions? I would like to go into some of the questions on the YouTube as well. So did you ever have any experience on detecting prenatal rubella syndrome?
Not
cataract or congenital heart disease?
Cataracts, yes. I think ultrasound is in fact better at picking up cataracts. I would give that a very difficult diagnosis on MR. In fact, the lens looks uniformly T2 hypointense with the surrounding fluid around it. But would we go as far as calling it rubella? Probably not. I think we can at least pick up the abnormality, and then if it's a unilateral or bilateral cataract, it could be both environmental and genetic. So I think that kind of triggers the rest of the pathway in terms of evaluation. But I think if the question asker has seen a case of rubella, they should probably be asked to display it, and it would be really good learning from a case like that where you could, on the spot, diagnose rubella just on a scan.
Dr. Rama, have you diagnosed congenital rubella syndrome?
The problem with rubella syndrome is that a big component of it is neurosensory hearing loss, sensory neural hearing loss, which ultrasound, it's not a structural problem, it's a functional problem. So we don't get to do anything regarding functional problems. If you look at ultrasound, it is only for structure. And if there's a cataract, yes, we pick it up. If the brain is infected and if there are sequelae in terms of heterotopias, in terms of lissencephalies, in terms of periventricular, in terms of a hydrocephalus, in terms of nodules underlying the ependyma, we can pick all that up. But if the brain is not structurally affected, we are lost. Because in the fetus, infection does not equal fetal affection. A fetus could be still infected, but not structurally affected. So it's only the structural affections that we can really pick up on ultrasound.
Great. Ramesh?
Okay, I think we will go ahead with Dr. Mankad's second part of the talk, and then we'll come back to the discussion.
Absolutely.
All right, thank you very much. Yes, I'm looking at the clock as well. So we'll go a little bit quick with part 2 and then show you a part 3. I did promise to show you the retinoblastoma from my good colleague in Boston. But part two is about brain watch. You look at the eyes, you have to look at the brain after that. And I think the dictum is that up to, in fact, more than 90% of patients with ocular or globe abnormalities have concurrent brain malformations. If you have exquisite ultrasound like Dr. Ramamurthy does, okay, I give it to him. But I think there should be a very, very low threshold. In fact, there should be no threshold, 0. You should be switching to an MRI for further evaluation. That also becomes tricky when the gestational age is quite young. So report none of these 3 cases without knowing the gestational age. I think that's relevant. But at the same time, you've got eyes on both sides, but you have to decide if there is one small, one big, or both are big or both are small, or if there is an associated finding going on with it, or if there is something else that you're not expecting to see at that particular gestation age. So first patient here from this armamentarium of brain syndromes is this 30 gestational week study. And you can see that there is an asymmetry of the eyes, and I've put some black arrows to show you the rest of the brain. So you've looked at the eyes. In fact, you might have looked at the brain before and you went back to the eyes and you're wondering what this turns out to be. This is a case from my friend in Philadelphia showing you an early gestation scan of the Z-shaped deformity of the brainstem and the additional finding of clefting of the brainstem that you can see on axial imaging. And if we had greater clarity on the Zoom, it's not showing too well. But for 30 gestational weeks, essentially that cortex was extremely smoothened out. We don't make an instant diagnosis of cobblestone malformation, which is what this is in a sense, but the Z-shaped deformity was more strong to call this a CMD or a congenital muscular dystrophy in the context of a dystroglycanopathy, the alpha subtype, and the diagnosis was prenatally genetically confirmed as a muscle eye brain disease. So multisystem polygenomic kind of entities, the CMDs are, you've got muscle eye brain, you've got the Fukuyamas, you've got Walker-Warburg syndrome, and all of them kind of cluster around the dystroglycanopathies and a few mutations that are known that can be screened for. And it seems to be a common theme that the sister concern of muscle eye brain is this scan from our own archives. Scanned at day 1 of life, there was a problem on the antenatal imaging. So we had a low threshold. The parents wanted to continue with the pregnancy. And we managed to, again, demonstrate the Z-shaped deformity of the brainstem out here. And along with that, you have a large ventricle. Now, when you have large ventricles, the temptation on ultrasound would be to call this hydrocephalus. But whenever you have large ventricles, look at the brain around it. And of course, you need to know whether this child attained any particular gestation or not. And there were 31 weeks. So everything that you're seeing in the form of cortical development is anomalous here. I still don't use the word cobblestone freely because when I use cobblestone, I'm already targeting the gene testing in one direction. So kind of try to leave it a little bit open because now we have emerging tubulinopathies, for instance, which also seem to have this kind of configuration to the brainstem. What were the ancillary features here before we get to the eyes? We have little cysts within the cerebellum. The cerebellar foliation in itself is anomalous, a bit of clefting happening in the brainstem as well. And once again, on the coronal, you see the folding of the cortex is completely wrong on both sides. Difference in the size of the eyeballs and what was initially read here as persistent fetal vasculature, not exactly the typical morphology of that. It turned out to be optic atrophy, retinal dystrophy, and an overall non-functioning eye on one side. So you can see there's a big overlap between muscle eye brain, Walker-Warburg syndromes, with the imaging phenotype being quite strong. And then, of course, you go back and look at the gene tests. And in fact, more emergent and recent literature is on COL4A1 mutations, which can cause both phenotypes as well. So single mutation driving similar and slightly different morphologies. So here we have just seen an example of alpha dystroglycanopathies and the element of face and eyes predicting the brain. One more finding on this particular scan is also the ears. At the day 1 of life, we should be seeing a little more out there. So they had bilateral cochlear hypoplasia as well. So bilateral cochlear hypoplasia, an eye syndrome, and a brain syndrome to go with it clinches the diagnosis. Let's think a little bit about this syndrome. This will come across a lot more in practice, particularly when you either detect hypotellurism or even a microphthalmia or even frank anophthalmia. And remember, on any form of imaging, it's not always easy to tell the difference between microphthalmia and anophthalmia, because in anophthalmia, the non-neuroectodermal derivatives should still be present, but they're very hard to see on the quality of images we get at times. So I always take my imaging with a pinch of salt. I don't swear by it. The quality of images is determined by the scanner as well as the patient that we're trying to scan. But here at 34 weeks gestation, you might want to think about the folding of the brain. It looks a bit over-convoluted in parts. Definitely there is an underdevelopment of the frontal lobes, and the opercular are also wide open. The brainstem looks overall small, but I can tell you that the problem really is more of a cystic enlargement behind of the arachnoid cyst that you see. There is hypotellurism, and you will not be able to squeeze comfortably another eyeball in between those two eyeballs. So in this context, you are left with a list of non-specific entities. So there is a bit of a dysgeuria, dysmorphology of the brain, hypotellurism, and then you're going to start wondering about which test. And you can see that it's not always easy to exactly pinpoint and say this is the diagnosis. This turns out to be trisomy 13 or Patau syndrome, which you will quite commonly encounter in the context of eye problems and gyration problems in the brain. More importantly, let's look at a companion case of a trisomy 13 and the bandwidth of possibilities that it can offer. This was a 21-weeker, so we have to be a little bit cautious about the gestational age before completely labeling this, but I think there's enough to call this a Dandy Walker morphology. That is a term that we are beginning to use since our last call-out paper that we did on the Dandy Walker morphology, rather than labeling it as a malformation in itself. And in addition to that, you have the clefting of the brainstem, the absence of the eyes out there, and then on this companion case here, the fact that the corpus callosum is quite severely dysgenetic as well. So, the different possibilities are going back to the same mutation, and we do know that trisomy 13 essentially is well known to be associated with many other entities affecting the eyes, including PPHV or persistence of the primary vitreous circulation, for instance. And here to complete the ring on syndromes are a few more cases. This is a coloboma. As you can see, I've encircled it out there. There is callosal dysgenesis, or in fact, quite a severe dysgenesis that is called agenesis. The purists will tell you that there is no entity called corpus callosum agenesis. There is always a little bit of tissue that connects the two bits, and that definitely is the teaching that my colleague Dr. Taranath does from Adelaide quite eloquently, if you ever have the ability to listen to him. And it's a bit of a misnomer, but yes, we still use the term because that's what people understand. You have parallel ventricle orientation, and the lateral ventricles are also dilated. This is called colpocephaly, and you may have a high riding third ventricle, and sometimes you can even have a frank interhemispheric cyst. What is important to pick up is little heterotopias in the context of calling this a fetal Aicardi syndrome. And remember, you don't have to pick up colobomas, etc., on both sides. Once you pick up a cerebellum that looks a bit missing on one side, you have to think about two possibilities, whether there has been an environmental or a vascular insult, or this is a syndromic diagnosis. You can see the bilateral colobomas here. And in fact, you can even get the morning dysglory in this particular entity. It's a difficult distinguishing call to make on the fetal MR. This turns out to be Faces syndrome. And on the contrary, here you have a missing ear on one side, a missing eye on one side. You're going to definitely entertain a diagnosis of an oculo-auriculovertebral syndrome. More difficulty into the realms, case from Colorado. The arrow is looking at a skin tag, and I think Dr. Rama Murthy was trying to show you a skin tag. So this is a 3D reconstruction, which MR makes very well possible, and the clarity of that in terms of the dysmorphology is going to be quite nice. This is a skin tag in association with a significant migrational abnormality. This is a cortical malformation involving the frontal lobe on one side, and the fact that this was referred to as microphthalmia/anophthalmia on the left. Therefore, you could entertain, just based on the imaging, a differential of Delman syndrome, which is also referred to as oculocerebrocutaneous syndrome. But it's not all about getting the exact diagnosis. It's about persevering to find out all the various manifestations of a particular disorder that we are trying to exclude or include in our differential. So that's a little bit about syndromes. Final part is focal lesions. 3 different cases. Okay, some of it has been broached previously, so I will swift that. Otherwise, here we have the first case, and this is a case from my friend Camilo in Boston. You talked about getting cases from all over the world. We are constantly collaborating, and that is the whole idea of trying to improve and up our own diagnostic game. So this was an ultrasound pickup in a family with germline RB11, which is highly suspect for retinoblastoma. We cannot be more specific. Can it be picked up early if it's there? Yes, but it is a catastrophic diagnosis to entertain because it puts a lot of pressure on the system as to what to do next. The MRI was done. The MRI picks up the abnormality as well. Rest of the brain looking okay for its gestational age at that point in time. Yes, it is a retinoblastoma. The family was already at high risk, and this is what it looks like. So you can see how unspecific it can look like, particularly when you see its sister concerns that we'll be showing to you in a moment. And then you have to, I think, wait out for the time. You might have to repeat the scan and consider other possibilities as well, because that cannot be sampled in itself. This is the sister possibilities when we think about the child now will be born with a white reflex. So you've got retinal astrocytic hamartomas associated with NF1s and tuberous sclerosis, looking for ancillary findings of calcification. So it's not just specific to retinoblastoma that you pick up calcification. We don't do fetal CT as such. But if we did a postnatal CT, you could pick up calcification in the retinoblastoma as well. And then this entity of persistent fetal vasculature, which is a new name for PPHV. This is exactly what it should look like a soft retrolental mass, and it may be proceeding towards the optic nerve disc, and essentially a diagnosis that you should not really make before 30 weeks of gestation because persistence is normal up until then, and the failure to involute after that is a problem. It's called a benign entity. It is one of the biggest mimics of retinoblastoma for some reason because it presents with a white reflex. The problem is people say no calcification and the globe is small. That is right. But I have seen retinoblastomas also with small globes. They're not always big. So I don't think that always works, and it has not been systematically looked at. Here's a companion case, and I've seen at least 3 cases like this. I've also seen children from Philippines who have been on 2 or 3 courses of chemotherapy for suspect retinoblastoma, and this is hemorrhagic with retinal detachment. It is diffusion restricting, and that is what the problem was here. But the diffusion restriction comes from the fact that it has hemorrhage, calcification, lots of protein, lots of inflammation. Everything can restrict diffusion, so it's a bit of a pitfall. But if you look at beyond all that, you see the PPHV, so to say. So this is also basically persistent fetal vasculature with the complications of retinal detachment and hemorrhage. This was never a retinoblastoma in this child or even on the child from Philippines general, but they were subjected to 3 cycles of chemotherapy because treatment across the world is still not standardized and the cost of care is still not excellent for the World Health Organization to start talking about getting it right the first time. So companion case, one of the closest differentials to the white reflex is Coates disease. We know about it. And if you think about the prenatal scan that I showed of the retinoblastoma, it looks pretty much like that. It is a retinal telangiectasia and essentially a secretion of lipoprotein exudative material that is subretinal. Yes, it can lead on to retinal detachments in future as well. And generally, they don't enhance. But when we look at the other spectrum of Coates disease, which is still very rare, and this is Coates plus disease, which is a multisystem small vessel angiopathy, also referred to as CRMCC, which is cerebroretinal microangiopathy with calcification and cysts, multiple associations with our usual suspects. Yes, it can calcify. This is a CT scan zoomed in quite badly out here, but that's a little lesion. This is CT scan, but important again to look at the brain even postnatally, and this child had chunks of calcification in the context of Coates plus disease, referred to now as CRMCC, CTC1 mutation, and apparently, correct me if I'm wrong, it is known to be a ribosomopathy, which is what is the new thinking around these entities is. So Coates and Coates plus. This is my final slide. And why do I show this slide? I show this slide because I think people are learning a lot from social media. You can see whoever put this slide together on Pinterest has put a lot of effort in trying to explain and reach out to audiences. So a lot of respect for people who do a lot of illustrations-based teaching. And I think I have not made this, and I would have spent hours doing this, but it shows nicely the differentials of leukocoria, and subjecting it to random and rapid access memory would be quite useful when we think about the possibilities that lie beyond. Going back to the final thoughts, whether it's postnatal or prenatal, don't forget this. We didn't start there because this is the boring way to start an orbital talk. You still have to think about your 3 spaces, the 4 compartments, and the 3 apertures when you're trying to understand where the pathology is resident and what it's doing to its neighboring structures. I thank you for your attention.
Fantastic. I mean, I wish we had more time. Absolutely amazing. Ramesh, do you want to take the discussion, and I will start sharing the slides? How's that?
Yeah.
Let me go.
Any questions from our panels? Hannah, Rita, and Louisa?
Yes, I would like to make a question. I'm sorry. Congratulations. It's really beautiful to see all this presentation, all these images. I've been learning a lot. I would like to ask Dr. Mankad if there's a role of MRI to diagnose the agenesis of the cranial nerves or fibrosis of the extraocular muscles.
I think you're talking about the context of tubulinopathies here. Let's break it down a little bit. Extremely difficult. Let's go backwards. If we have a small cochlea like we had with the dystroglycanopathies, we can suspect that the 7th and 8th nerves will have a problem. If we have a small brainstem or an asymmetric brainstem, then we should be beginning to think about cranial neuropathies that could be associated in the context of Mobius. I'm yet to have complete clarity on cranial neuropathy on a fetal MR. And I think hopefully in the future, we'll be more confident about it. But at this point in time, picking up fibrosis on MR in itself, even postnatally, is extremely difficult. I did see a cluster of tubulinopathies when our ophthalmologist asked us this very question. First of all, the imaging that exists for most of these patients is not even attuned to cranial nerve assessment. And then we don't know what the normal metrics are in terms of normal thickening of these cranial nerves. So it is work yet to be done.
Ramesh, I'm going to interrupt a little bit for the sake of time. I'm going to go to our panelists and just say, Hannah, let's start with you. What's your take home from these two, to me, I mean, absolutely phenomenal presentations, things that I would never have thought that we could do before. What's your take home today, Hannah?
Yeah, I mean, in genetics and genetic counseling, we focus so much on getting complete histories, and we do take, a thorough prenatal history, but who knew that we could actually get the expertise of, the wonderful talk today and think about what it means to not just ask the question, but to actually see the pathology. And so for me, a big takeaway is parents, are often finding out these diagnoses after the fact, and you can't do anything earlier of a diagnosis than during prenatal. So really starting to think about, can we leverage the ability of prenatal ultrasound, getting more detailed scans, and saying, if we know there's a family history, if there was a previous poor outcome in a pregnancy, should we be asking for these types of scans to get the earliest diagnosis possible? And that is something that I'll certainly be thinking more about than just asking the questions, which is kind of what I think we usually focus on.
Great thoughts. Louisa?
So I have a couple of points here. I think the prenatal diagnosis helps a lot, the early management for all these pathologies, and prepares both the family and the team that will take care of that child to have this multidisciplinary approach. Certainly, to have the ultrasonography carefully performed, especially in families with a history for example, retinoblastoma or other ocular inherited disease, and have that information sent to the ultrasonographist before the exam. I think that is very important. To have a prenatal MRI for those suspected cases and discuss with the radiologist all the possible diagnoses. sometimes, like Dr. Case showed, to do serial exams to follow the evolution of the image. Always carefully look at the brain. And I think one very important thing that I learned is that even for these amazing experts, they might be seeing for the first time a pathology and take that advantage of the technology to discuss with specialists around the world.
Amazing. Rita? And then Ramesh, I'm coming to you.
Well, 2 points. First of all, is the great connection between the brain and the eye, which we already knew. But I think both of our speakers talked about starting with the eye, going to the brain, and back to the eye. So this incredible connection. And whenever we think about malformation of the brain or the eye, we should ask for these exams that don't replace the genetic investigation, but rather reinforces it.
Perfect. So, Ramesh, I'm going to give you my thought, then I'm going to let you finish off on the webinar. I've come away with 2 lessons today. Number one, I have to form a relationship with somebody in my ultrasound department and somebody in my MRI department, either at the Women's Hospital, we have a McGee Women's Hospital in Pittsburgh, to make sure that there's a point of contact, because communication is always the way you develop the ability to deliver better care. That's my first point. My second point is clearly ultrasound and MRI complement each other. And with ultrasound being done regularly, it's the gateway to picking up prenatal diagnosis and then going to MRI. Ramesh, leaving you with the final thoughts, and I'll run the slides for you.
Thank you, Ken. It's a brilliant talk. I just learned what is possible with the imaging. I think it's extremely complementary along with the genetic test. And the story around the imaging, both MRI and ultrasound, I think we should make best use of it. And I wish more and more specialists are there around the world. This will really help us to give the best care to our patients. I would like to show some slides with some final thoughts. Some of your audience, if you have any more questions, please email to us. We will respond to you. We'll ask the expert, we'll send it to experts and get back to you. We continue to have this kind of webinar every month. The next month, we are going to have a webinar on strabismus management, tips and tricks from different continents. This is being done as a virtual symposium at Ukrainian Association of Pediatric Ophthalmology annual meeting. And we have fantastic speakers here. And I would like to ask you to join for this on Saturday, 8th June 2024 at 2 p.m. to 3:30 p.m. GMT plus 3 hours. Most exciting 5th World Congress. All of you know that it's happening in KL. Please do join us. It's going to be a fantastic meeting. We have very large presentations from many parts of the world, and these are the keynote speakers not to be missed during those meeting. And it's going to be a fantastic meeting with a lot of network and seeing most of your friends around the world during this time. Next slide, Ken. We have highlights. You can go to the website and find out. If you have not signed up, please do sign up today. And today is the last day. If you want to take quiz and get the complimentary registration, you can do that as well. And that's what the complimentary registration. Go ahead. And we always request you to join us at WSPOS member. It's free. It's absolutely free. We have a lot of advantages of joining this. And please write an email to us and be a member, and encourage your residents and fellows and other pediatric ophthalmologists to join so that they can, we share education materials for them. And last but not the least, we also have a pediatric listserv. If you are interested, your students or the fellows are interested, The email is there on the slide, and you just send an email with the details below. And the last thing I would like to do is thank you for our audience. And you've been great with a lot of questions and interacting on the YouTube. And I'm sure it was a great webinar for me. I learned a lot. I'm sure the audience also would have learned extremely from this the meeting. And I would like to thank both the speakers and the discussants and Ken and all the administrative people at the WSPOS. Last but not the least, the NTOD and its team for delivering this webinar through the online portal. Thank you so much. Good night, good evening, and good morning to all of you, and a big namaste to everyone. Thank you so much.
Just the last word, I want to say, Dr. Rama, Murthy, Dr. Mankad, I have never heard such an amazing pair of talks. Thank you so much. You're outstanding individuals, and we're very, very grateful to have you on board. Thank you.
Thank you for calling us.
Everyone.
Thank you.
We are both from Bangalore Medical College, by the way.
Clearly. Okay. Bye-bye, everyone.
Bye. 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 Bye.
Thank you. Thank you.